Okay, it's 1 o'clock in New York City, 6 p.m. in Lisbon, 7 p.m. in Brussels, right? If I'm not wrong.
Luxembourg.
These are
Same
not.
thing.
Okay, Luxembourg. Hello, everyone, and thank you for joining us today. It's a real pleasure to welcome you to the MSK Case Presentation Series. My name is Aline Serfati, and I'm honored to co-host this series alongside Dr. Hillary Humans, who has been coordinating and moderating this series with me now for 5 years. Our guest speakers today are Drs. Angela Atinga, Paulo Simoni, and Remy Mansour. And together they will present a series of interesting cases highlighting the most relevant image findings and providing a literature review to enrich the discussion. And at the end, we will have a Q&A session. If you have any questions at any point during the presentations, please write in the chat box. And at the end, the speakers will answer to them. Today's presentation will be recorded and available on demand on the OCAD website, which is ocadmsk.com. Now, Hillary, it's your turn.
Okay, great. Thank you, Aline. Aline, by the way, your co-host, if people are requesting to join, please let them in.
Okay, I
Okay.
will.
Okay, we're going to kick it off with Dr. Angela Atinga. She received her medical degree at Cambridge University in the UK and completed her diagnostic radiology residency at the Imperial College in London, followed by 2 years of clinical and research fellowships in musculoskeletal radiology at the Joint Department of Medical Imaging at the University of Toronto in Canada, where she's now on staff as an academic radiologist and assistant professor. Apparently, in her spare time, she racks up musculoskeletal injuries and practicing Pilates. And this is most interesting, she's studying to be a fledgling sommelier. Sommelier? How do I say that in French?
I think you got it.
Sommelier.
Okay, thank you.
Okay, so I'm just going to share my screen here. Second. Am I allowed to share it? Hillary? Okay, yeah, perfect.
Let me see. Yes, you're sharing
Okay,
now.
perfect. Hi, everyone. Thank you so much for joining us. So my case today is maybe a relatively simple one, but I think it's always good to revise the things that we've seen before and don't have at the front of our mind. I have no relevant disclosures. So this is a case of a 24-year-old male patient who was an avid runner and presented with 1-year history of intermittent nagging posteromedial pain, which was worse primarily with activity, no pain at rest. He had no specific history of antecedent trauma. His physical examination was remarkable only for posteromedial knee pain on palpation. The patient had a full range of motion. There was no laxity on cruciate or collateral ligament testing. His McMurray's test was equivocal, so he had a little bit of pain testing on the medial meniscus, and the MRI referral was to rule out a meniscal tear. These are his initial radiographs, and as you can see, they look normal. There's no sign of a fracture. The joint space is maintained. I think he had a small effusion at the time, but nothing else really. This is the MRI study. So I'm just going to roll through just 2 sequences that I've selected here. So just keep an eye on the video. Hopefully they won't move too fast. And I'm just going to go through them a couple of times. Okay, so that's the sagittal T2 fat sat, and I'm going to play that one more time for you here. Okay, and these are the axial images here. So we were really struggling to find something abnormal in this patient, but we kept in mind that he had a history of posteromedial knee pain. His menisci were also an area of interest for us here, so just going to roll through that one more time. But we really focused on the posterior medial corner of the knee. And the only thing we could see here was the patient had some mildly increased signal in his semimembranosus tendon and at the posterior medial corner of the knee, which we know can present in patients who are runners with posterior medial knee pain. So we were happy to diagnose here posterior medial knee sprain or posterior medial corner sprain with semimembranosus tendinosis. But the fellow then reported that the patient also had an anterior horn meniscal tear, and this was the image that they'd saved and pointed out. So I went back again to look at the images, and you can see here, just focus on that anterior horn of the medial meniscus. You can definitely see a cleft there. You can see it on more than one or two slices. And so it was not unreasonable for them to think that this patient had an anterior horn meniscal tear. This led into a discussion. So these are just the still images here. And this led us into a discussion about the attachments of the medial meniscus anterior horn. In fact, all the root attachments of the menisci are of particular interest because we know that root tears contribute to an unstable meniscus with accelerated degeneration of the cartilage in the joints and accelerated osteoarthrosis. This has been a particular area of interest. Most recently, this paper was published just a few weeks ago from a group out in Belcrest, looking at the attachments of the medial meniscus on 7 Tesla MRI high-resolution imaging. And what they showed as the most common attachments of the anterior horn of the medial meniscus here, we can see was this attachment here to the slope of the anterior margin of the medial tibial plateau. And on some occasions, they would attach more centrally towards the tibial eminence along the flat aspect of the anterior tibial plateau. So these are the two most commonly recognized meniscal attachments of the anterior horn. And I'm just going to show you some examples of those in still images. So you can have this attachment here to the flat aspect at the anterior aspect of the medial tibial plateau, really close to the intercondylar notch. Or you can have this more vertical attachment, which is more to the anterior slope. And sometimes it can be really almost along the anterior cortex of the medial tibial plateau. What we don't think of often is the anomalous attachments of the medial meniscus. So there's a uncommonly recognized attachment to the ACL. This might be to the ACL footprint or actually to a fiber that attaches and blends in with the ACL itself towards the medial femoral condyle. So this is called the anomalous insertion of the medial meniscus to the ACL, or in some cases it can be referred to as the anteromedial meniscofemoral ligament of the medial meniscus. And that's what we have in this case, which is misrecognized as an anterior horn meniscal tear. So if you just focus on this tissue here, as I roll through the images again, you'll see that there is this band of soft tissue. So we're coming into the anterior horn of the medial meniscus here. You can appreciate that band of soft tissue, which is running into the intercondylar notch as we go back there towards the ACL, and it is extending from the anterior horn of the medial meniscus. So what we're seeing as a cleft is actually the takeoff point of that ligament. This is an incredibly rare normal variant with an incidence quoted at approximately 1%, but varies in the literature from 0.3 to 1.2%. In about 74% of cases, you have a false positive rate for an anterior horn meniscal tear. So it's something to be aware of because we do misclassify these. They're often asymptomatic in an incidental finding, but they can cause vague anterior knee pain, which is thought to be related to impingement against the medial femoral condyle during motion. So that anterior horn of the medial meniscus, when it attaches to the ACL, may be more mobile. And so patients can present with this vague anterior knee pain that can even mimic patellofemoral pathology. And here's some cases just to show you what it looks like when you have these and what they can mimic. So in this case here, this is a patient with a bucket handle tear of the medial meniscus. And you can see how that tissue, the flip tissue in the intercondylar notch, will very easily mimic what you see with these anomalous insertions or with these ligaments. So it's something for us to be aware of when we're reporting. So I'm just going to move on here. So you can see that bucket handle tear of the medial meniscus will look very similar to what you see with this anomalous insertion onto the ACL. Here is a different case where you have a patient with a true anterior horn medial meniscal tear. And this one is more complicated because you have both the transverse ligament in view and you also have a flap of meniscal tissue. So if I just run back there, you can see the transverse ligament is just positioned here anteriorly, and this is a meniscal tear here. But if you're not thinking about that or you misrecognize this, you might call this a normal variant. It works both ways. You can not only can you misclassify a meniscus a normal insertion as a pseudo tear, but you can also miss tears considering that these are normal variants. So just something to be aware of. This is just still images of that anterior horn meniscal flap tear. So my take-home points here is that there are multiple meniscofemoral ligaments and recognized meniscal variants, but majority of these are well characterized and usually related to the posterior horn of the lateral meniscus. Lesions affecting the anterior horn of the medial meniscus are incredibly rare, less than 1% of what we see in imaging, but they're important because we misclassify them in almost three-quarters of cases that we see. And this particular variant is very rare, so it's the same thing, the anterior medial meniscofemoral ligament or the anomalous insertion of the anterior horn of the medial meniscus. They mean the same thing. These are rare, but just something to be aware of when you're reporting. One, not to miss them, because in rare occasions they can be symptomatic and can be resected, but also to make sure that you're not misclassifying them as a meniscal tear or in some cases as an ACL tear. And that's the end of my case. Thank you.
That was a beautiful case. Thank you.
Thank you, Angela. Now it's my great pleasure to introduce Professor Paulo Simoni. He is a consultant musculoskeletal radiologist at Centre Hospitalier de Luxembourg and invited professor of radiology at Università Campus Biomédico de Roma. Trained in Rome, Brussels, and Liège, he previously led the MSK unit in Liège and the pediatric imaging department at Queen Fabiola Children's Hospital in Brussels. His academic work includes a PhD in radiographic joint space assessment, more than 100 peer-reviewed publications, 14 book chapters, and the editorship of a Springer book on pediatric MSK radiology. He's an active member of major European and international radiology societies, founder chair of the ESSR subcommittee on pediatric MSK imaging, and a frequent invited speaker at leading radiology congress. Please, Paulo.
So I'm presenting the case. Thank you for this invitation and for your patience. I'm presenting a case in which basically we don't have any new competence or information. It's just a way of reporting or looking at it. So the problem is not here knowing the different elements, but following in the report a reasoning to discover a pattern. This is a case of a 32-year-old man with acute trauma of his ankle with a couple of radiographs was not very optimal performed during the on-call. And here we are supposed to do diagnosis, fracture or no fracture. And you can see here that the soft tissue are not normal, and you can spot some abnormalities of the posterior aspect of the tibia here, and some other lines which are very suspect here on the lateral view. What we have to find in this case is all the sign that you know, the medial clear space, the mortise, is there or not a fracture of the lateral malleolus or medial malleolus, if there's also sign of a possible fracture of the posterior malleolus, possibly using the spur sign, namely the irregularity of the posterior aspect of the tibial plateau, or a step off of the articular surface of the tibia. All these different signs can be reported in our report, and we can also use very poor quality X-rays to spot, for example, here a fracture of the posterior malleolus, which can be seen here with using this sign that I discovered in the last two years. I didn't know, I wasn't aware about this sign, the Misty Mountain sign. So the appearance of the fracture on the frontal view. that suggest the presence of third malleolus. And we can also perform a CT and detail this fracture. Is what we are supposed to do, but basically we are describing a trimalleolar anchor fracture. As a reminder, malleolus in Latin is liter hammer, and we are just describing the pieces of a pattern which is basically well standardized. The best thing to have a better report is to use Weber classification and first of all establish if the fractures is under syndesmosis, through the syndesmosis, or up to the syndesmosis, because we can predict three major patterns: the Weber A, Weber C, Weber B, and Weber C, and see and predict the sequence, the precise sequence of the different abnormalities that can be present even on poor quality radiograph during the on-call. And we can also predict what is not evident on the x-rays, namely the lesion of the ligaments. And the pattern is very precise, and if we look at this pattern from the above, this is the talus, and we are looking from above, the pattern is typically anti-clockwise, is clockwise, and is start for the Weber C, the transsyndesmotic lesion, from the ligament, the anterior inferior tibiofibular ligament, and proceed to the fibula, and posterior is a ligamentous or a bone fracture, and finish medially to the medial malleolus. When the fracture at the level of the fibula is superior, and so we are facing a Weber C fracture, the pattern is clockwise, but it starts from the medial malleolus. And basically, if we have a fracture of the medial malleolus, we know that the next fracture is at the level of the syndesmosis, and the last fracture is at the level of the third malleolus. And as you know, we can also predict the mechanism at the base of the trauma. And interestingly, when we have a fracture which is low, which interests the lower part of the fibula, we never have, for example, a third malleolus fracture. So we can predict based on what we see on the radiograph, what are the sequence of the lesion we have to precise in our report. This is a very standard case in which we have transdesmotic fracture, and we know that if we have a fibular fracture, we have to be also predict the presence. And if we have a medial malleolus fracture and an abnormality of the medial clear space, we know that we have a posterior malleolar fracture. It's quite mandatory. The importance of the knowledge of this pattern can be also illustrated by this other case in which we have an evident abnormalities of the medial malleolus and the posterior malleolus, and based on the pattern, which is typical of the Weber C fracture, we can also add another set of radiograph that reveal a typical Maisonneuve fracture. So we can overlook this fracture if we only describe the elements that are present in the first set of radiograph. This is a last case with another set of poor quality radiograph, because you can easily see that it's not a standard lateral radiograph. And we can see that basically there's no main abnormalities on the x-rays except from the swelling of the lateral soft tissue near the lateral malleolus. But because the clinical examination was so suggested a medial or internal soft tissue swelling, another set of radiographs was performed, and a Maisonneuve fracture was discovered and not overlooked. Let's see and for this particular session, let's see the MRI, which is ordered by the clinician, and we can see here that the pattern that we described is easily recognized on MRI. So medial collateral ligament, the deltoid ligament, and then laterally the tibial fibular interosseous membrane, the inferior tibiofibular ligament, and also the talofibular ligament. And noticeably, there's no fracture, which should be the fourth lesion in the pattern of the posterior malleolus in these images. Obviously, you can see all these abnormalities in the 3D. What I do, probably you do the same thing. I also see the sagittal and the coronal view to explore the lateral and the medial collateral ligaments. And I also learn to describe, when I have a three-dimensional imaging, a CT or an MRI, the extent of a or the third malleolar fracture, because what the surgeon wants to know is basically how large is the involvement of the fibular notch and whether or not the medial malleolus is involved, and why. Because in fact, if the lateral part of the ankle is involved, you have to enter from the lateral side, and he has to avoid the sural nerve, and if you have to fix a third malleolus, he has to avoid the neurovascular bundle, and in particular the tibial nerve. So, what are the key points to report in a case of an ankle fracture, and more extensively in a case of a three-malleolar fracture? The morphology. Using the Weber classification could be a good idea, because in the case of B and C Weber fracture, we can also be able to rule out a posterior malleolar fracture or a posterior syndesmotic fracture. The fibular involvement with the degree of displacement, because it can guide the surgeon in have a good approach to this fracture and to avoid important structure on his way. Obviously the state of the mortis, and possibly the extension to the articular to the joint of the fracture, and also to the fibular notch. So the three take-home messages on these very basic cases. The pattern on the sequence on the ankle lesion in adults can be predicted using the Weber classification, and using this classification, some ligaments involvement which is not obvious on the MRI, on the X-rays, can be predicted and eventually clarified by ultrasound, or if is necessary by MRI. And in case of trimalleolar fracture, is now established in literature that CT plays a key role in determining the position, the number of fragments, thus guiding the surgical plane also to give a better idea of the prognosis of this fracture. So thank you for your attention. I stop the sharing.
Perfect. Thank you, Paolo. Okay, now it's my pleasure to introduce Dr. Rami Mansour, who is an associate professor at the University of Ottawa and was previously served as clinical lead for musculoskeletal imaging at Oxford University Hospitals. Dr. Mansour was the MSK team lead of the European Diploma in Radiology from 2019 to 2023, and the former Royal College of Radiologists Global Ambassador from 2022 to 2025, and former RCR BSSR Traveling Professor from 2019 to 2021. He served as regional coordinator of the ISS Outreach Program for the Middle East and North Africa from 2017 to 2025, and he's delivered more than 500 invited lectures in Africa, Asia, Europe, and the Americas. As a member of the British, European, and Asian Musculoskeletal Societies and Skeletal Society of Radiology and International Skeletal Society, he is truly as international as OCAD. Okay.
Thank you, Hillary.
I took some liberties with your bio.
Yeah, no worries. That's why I didn't want to send all anyway, my bio. So thank you for the invitation and thank you everybody. And today I'm going to present a main case and two companion case for a common lesion that probably I can argue we see every day, but radiologically was presented with uncommon radiological appearance. So this is the first case, and you can see this is an 80 years old male, and he was presented to the emergency department with a PE, the diagnosis of PE, syncope, and breathless. And he recently done a prostate surgery, and there was some kind of malignant cells and atypia. But initially, they were worried about what's going on with the chest. And you can see in the first CT, they showed this bone lesion, which looked very much like what we call a typical hemangioma. You can see prominent trabeculae, and you can see the dotted polka-like. And in this CT showed that there is a soft tissue swelling here in the right paraspinal insert. However, this soft tissue swelling was not reported in this chest CT because, of course, the main interest was to exclude PE, and there was no PE. The patient was not feeling well, and he presented again after 2 weeks with the same symptoms, done another CTPA, showed the same, it was negative for PE, but then showed this again, this lytic lesion with this paraspinal lesion. And again, it was not mentioned in the chest CT report. It was just probably not seen. And the patient was dismissed, discharged from the hospital. However, after 3 months, he was presented again with weakness down the legs again, and some neurological deficit. And you can see on his MRI of the whole spine, of course, because of the history of the prostate, there was worried about metastasis. They show this kind of high signal in T2 and T1, which when we see this, we think of, this is fat, this is hemangioma. However, there was this kind of soft tissue component, and you can see it's already compressing the spinal cord. And the axial showed this paraspinal mass completely encasing the spinal cord, and it was really vascular in the post-contrast. So to be honest, at that time, they were not sure what's going on. Is this another malignancy? It is very vascular. It can be renal cell metastasis. Is it or something else? And you can see here again in T1 and T2 again, this was a fatty lesion. So the patient went ahead and done staging CT of CT abdomen pelvis, and you can see in the indication was progressive sensory and motor neuropathy. MRI spine showed canal stenosis, cord compression. So they just want to do staging if they were missing anything, especially in the kidneys. And again, on the CT showed these lesions again. And again, here in CT, there was something like more lytic. So at that stage, we are not sure what's going on and what this lesion is. Here it looks like vertebral hemangioma that we see every day, but the presentation is more aggressive. So the decision was, of course, to do a biopsy. They were worried about how the vascularity of this patient and the impending also pathological fracture. So the plan was to do embolization followed by vertebroplasty and biopsy. And that's what we've done. We embolize it, and you can see we've done vertebroplasty to support the vertebral body. We biopsied the lesion. Then after that, it was followed by decompression, and they were happy with the thing, and they biopsied again. So the patient had two biopsy, one image guided, and the other one was surgical. And the two biopsy was just simply one come back with a benign intraosseous hemangioma. So this is just an aggressive presentation of a benign intraosseous hemangioma. And the patient done very well. And you can see here the decompression, and you can see, unfortunately, because of the cord compression, you can see there is a signal there. So this is one of the cases. This is a companion case with the patient with the low back pain. She's 71. Again, this lesion, but this lesion radiologically was high in T2 and low in T1, so it doesn't show any fat. And again, there was a worry about whether it's causing some compression of the spinal canal here at this level. So the worry again is the primary, is it secondary? The patient is 71, they done PET-CT, and the PET-CT didn't really show any uptake. And the differential diagnosis at that time, is it something like multiple myeloma, like plasmacytoma, or nerve sheath tumor? So again, what we do is to do a biopsy. But again, biopsy twice, and there was no malignancy. And again, the biopsy came up with intraosseous hemangioma. Patient was followed up for a whole year, no change, and then another year, and patient was discharged as just a benign. And it was considered for sacroplasty. So, and this is another very similar case with, you can see here, not a typical appearance of a hemangioma, but the biopsy again came up with hemangioma. And this is in a younger patient with some encroachment on the spinal canal. So, and most of those patients, also this patient had PET-CT. We didn't show significant uptake. You can see here there is mild or moderate uptake, and very similar to the other levels. So it was not seen as potentially malignant lesion. So again, biopsy twice, same results. So now we'll just go some review about vertebral hemangioma. Probably we see it every day if you're reporting spine. They are benign lesion. They are very common. In one of the cadaveric study, they say it's like 10 to 12% of general population. You can argue this is like a even like a normal variant in our bone. They are mainly asymptomatic. The vast majority of them are asymptomatic. The best location or the common location is the vertebral in the spine, and mainly the thoracic and the lumbar spine. However, in rare cases, they can enlarge. They can even go pathological fracture and have this kind of associated soft tissue component. So histologically, this vertebral hemangioma has two subtypes. It's the capillary and the cavernous. And you can see, the capillary one, you can see there are small vascular cavities that is not really disrupting the osseous component. This is the bone, and this is the vessels, small capillary vessels or cavities. And the other one, subtype, is the cavernous, when you see a larger cavities of vascular cavities, and some of them that can even do remodeling of the bone, like here. So most of this atypical, radiologically atypical hemangioma, probably they are representing a cavernous subtype of hemangioma. And when we say aggressive hemangioma, this is basically is only a radiological description. It is not an histological description whatsoever, because even when those cases, the biopsy, most of the time they will just see a normal vascular component cavernous. So aggressive type of hemangioma, it is only a radiological subtype, not histopathological diagnosis. So this is the typical appearance that we see in MRI, high T1 and high T2, and reflecting fat component. However, as I said, when you do histopathology, it is not fat. It is just normal bone, but it is exaggeration of the fat component of the bone marrow. Okay, so there is no extra fat deposition. And you can see this typical um, um, coarsening or typical thickening of the vertical trabeculae. And this is very important because sometimes it can be problem solving in some patient. And on the axial, you have this kind of polka dot appearance. So radiologically, vertebral hemangioma can be divided in typical, and this is what we see almost every day or every couple of days. They are asymptomatic and they have typical appearance in MRI and CT, which is high in T1, high in T2, and have this polka dots. And the other subtype is the atypical, and again, this is the radiological classification. And it can be, has two subtypes, either asymptomatic, but not typical appearance, especially in MRI, but typical in CT, or typical appearance, but the patient is symptomatic. And as I said, a typical hemangioma does not cause pain. And I already showed you an example of the third type, which is the aggressive. And sometimes even the aggressive can have pathological fractures, presented with pathological fracture. So this is a case of a typical appearance on MRI, but the patient is presented with pain. And this patient was just all point to the point to where the lesion is. You can see here, this is T1, T2. They are high in T1, high in T2, which is a typical appearance of vertebral hemangioma. And when you do stir, it is suppressed. However, you can see those kind of two dilated vessels at the back, which make us wonder whether this is just definitely a hemangioma or not. You can see on enhanced CT, you can see the highly vascular lesion there. But the diagnosis here, because of typical radiological appearance, was a hemangioma. So one of the things that we can offer for those patients with symptomatic painful hemangioma is to do vertebroplasty. But before to do that, we've done a biopsy the lesion to confirm the diagnosis, and the patient went to do a vertebroplasty, and they respond very well from the pain point of view for vertebroplasty. Patient, after a few days, the feedback was the pain is gone, and you can see after a few weeks, even the dilated vessels is gone because all the vascular channels were obliterated. That's why it become smaller on size. So another couple of cases of hemangioma, just to show you that in rare cases, they can even have pathological fracture. Like this patient, you can see this is an aggressive type, and they presented the patient with a pathological fracture, decompression, and biopsy, intraosseous hemangioma. We've done, after that, we went there and went to vertebroplasty. The patient done very well. And even a younger patient with painful scoliosis showed pathological fracture. And the differential diagnosis, of course, esophageal granuloma. I'm sorry. And again, the same diagnosis was, I think. So in summary, hemangioma is very common. They have this typical radiological appearance. However, sometimes it causes us as radiologists some kind of difficulty in diagnosis when they have this aggressive appearance. In my experience, PET CT was always helpful on those patients because either they didn't show uptake or the uptake was very mild or moderate. And most of those patients can be biopsied and they will benefit from vertebroplasty. Thank you very much.
Rami, those were some scary images. Um, I sent you a couple of questions, but
Of
um,
course.
um, in that first case that you showed, I mean, I know that people can have multiple vertebral hemangiomas, but that case was striking because they were at multiple contiguous levels. And there was such a big soft tissue component. It made me think of hemangiomatosis that we see in the extremities. Is there such a syndrome in the spine?
Yeah, I think there is multiple, and the other one they are kind of angiomatosis or angiomas, or sometimes there's another which is the AVM, intraosseous AVM, with they are histologically different subtypes. As you can see that most of these patients were biopsied twice because we radiologically we are not really 100% sure. Uh, this typical, the first patient was the biopsied one under image guidance and the other one surgical biopsy. No, they are no, those patients are hemangiomas. And I think we discussed this with the histopathologists, and from the pathology point of view, they look straightforward. They don't have this kind of difficulties in calling them because they don't see atypia. They see this kind of dilated vascular cavities lined by the simple endothelium, and they call it aggressive based on radiology, by the
The
way.
imaging, right.
Yeah, not on what they see in the histopathology.
Pathology, they can't know about that. So also, how are the soft tissue components treated when they're encroaching on the canal?
Oh, it was decompressed. So the soft tissue become smaller after the vertebroplasty.
Oh,
So because when you inject you fill it with cementoplasty, vertebroplasty, it shrinks. Okay, because the vascular cavity become blocked with the cement. So the most of the time, the surgery is just to do decompression and just if possible, they can just take a biopsy, not to debulk it. Okay.
okay, great. This next question is for Angela. Um, oh, she answered privately, but share your answer with the group. So, Renata asked, do you usually mention the presence of these small knee ligament variants in your reports if they look normal?
I do. I'll put them in the body of the report, maybe not in the conclusion. I think it helps with continuity. If the patient goes and has imaging somewhere else, at least, somebody's mentioned it, even if you make the decision that it doesn't look pathologic. And then also for the surgeon. So we've had a couple of cases where a foot and ankle surgeon was doing arthroscopy and saw a ligament crossing across the front of the joint. And then they wonder if this is something that's torn or displaced. But if you've described a normal variant, they can always pull up the imaging in the OR and be okay. That's expected to be there. We don't think this is pathologic. So for that reason, I will mention them.
I agree. I agree. Very helpful. So, Paulo, my question for you is if you see the posterior malleolar fracture and asymmetric widening of the ankle mortise, do you have to chase the possible proximal fibular fracture radiographically since you already know the syndesmosis is torn?
So, first, isolated fracture of the posterior malleolus are extremely rare, but they exist. I have also a couple of cases in my private archive. Probably you do the same. You have the same. And I think, yes, it's important because if you don't have any fracture at the level of the lateral malleolus and you have a fracture of the medial malleolus or a swollen tissue on the zone of the deltoid ligament, you obviously you know that the mortise is not normal, but the pattern is very stereotyped. So you know that you have to pass by the upper part of the fibula to have a posterior fracture of the to have a posterior fracture of the tibia. So if to be short, if you have a medial fracture of the tibia or an injury of the medial malleolus near the malleolar malleolus, if you have also a posterior malleolus fracture, is quite sure that you have a high involvement of the fibula. So also for medical legal lesion, it's interesting to have X-rays of the whole leg because this fracture are sometimes overlooked because now we don't examine patients, so we don't, as you know, we don't prescribe X-rays ourselves, and you can miss fracture. Are they always? This is a question that I asked to our orthopedist. Are they always treated? No. Sometimes they consider that the fibula is not that important for the static, but for medical legal lesions, sometimes here in this hospital, for example, they had problems because people was not very happy that the fracture was not treated, even if eventually you can explain that this was not useful, but they want all the fracture documented for medical lesion, for legal reasons.
Got it. Eline, any questions?
Follow, yeah. Is fragment size still one of the most important parameter when assessing posterior malleolar fractures, or should morphology and syndesmotic stability take precedence?
Uh, Probably the syndesmotic stability, because if you have a good X-rays, you can measure some parameters like the clear space, the the superposition between the tibia and the fibula, and you can also predict also ligamentous lesion that can be the cause, as you know, of chronic pain because the scarring can be not optimal, and you may want to supplement the X-rays with ultrasound, which is quick and available to have a better vision. And so probably the most challenging thing is to detect on the standard X-rays. We have a high throughput of X-rays, also the involvement of the mortise. I found through the literature, which is the number of the overlooked syndesmosis abnormalities overlooked by general radiologists, and I didn't find any figure. So it's probably something that we don't do with an extreme attention in our practice probably to be solved by X-ray.
Sorry. Do any of you have weight-bearing CT? I mean, I know with high ankle sprain, it would be particularly helpful. I don't.
I don't, we don't.
Of 2025 about this particular technique. It seemed very fascinating, but basically, when they showed the case, one can must be not sure that it influenced the clinical decision because basically the clinician preferred to manipulate the ankle and evaluate physically the ankle with their test. I don't think they can rely on this alignment on X-rays. They want to do they maneuver themselves. So I'm probably is not well established. I don't know if other people have experience on this imaging. But what clinicians say, yes, I can see, but it's just a static view, and I want to do the test myself and explore this stability.
Sure. I think you misunderstood. I was talking about weight-bearing CT.
Yeah.
Yeah.
Yes, wet-bearing
Oh,
CT.
okay.
Yes, a wet-bearing CT because they wanted to correlate the fracture, the number of fragments, and possibly the involvement of the ligaments, even without contrast, and the disalignment of the pieces. And yes, there are some works, but it seems to me they are a little bit preliminary. And apparently, clinician wouldn't be that enthusiastic to use a static view for something which is basically dynamic, even if it's CT.
Right.
Okay. Is there any other question? Don't think so. Thank you all for joining us today. Our next session will be held on May 22nd. And you can stay updated by following our social media accounts where we regularly post information about upcoming sessions and related activities. Thank you, all the speakers. Thank you all for joining us.
Thank you.
Bye.
Thank you.